the person who qualifies for both HCBS and nursing homes, do they still have the choice of which one they want to use? Will they still have the choice?
So, choice is important. Here's what we're wrestling with. I'll be as transparent as I can be here. And let me ask you the question here in this room. Should someone have the choice to spend more than is needed to address their needs? Taxpayer money.
And then let me add one more.
In this case, we pay a percentage of the total. So it's a percentage of federal, it's a percentage of state, and some nursing homes bear a tax burden. So it's a mix.
The resident who has no family that qualifies for both on a lower rug level, then they're, because home and community based, unless something happens different, the access to them having, say, being in assisted living or in another setting, we have RCS, but they're not included in the payment process. There's not going to be that support system, and that's what we see a lot of times.
So the suggestion,
family works.
So the suggestion is that the level of, at least in terms of placement, that need incorporate. What I hear you suggesting is that need should incorporate.
Well,
family setting or community.
Right, because you put them in a place that there's families working all day. They maybe can take care of them at home on the weekends or their days off, whatever those days are. But there's no one there in the interim. And then I can see, they're not eating, they're not taking their medications at the right time, and they're going to be the ones that end up in Elaine's emergency room because they don't have that 24/7 monitoring of those medications and all, because there's nobody there to take it on. And a lot of times that's what the situation is.
Okay, additional perspectives. This is key, not maybe the core question we face, but one of the challenges we'll have to meet.
Dr. Allison, after the universal assessment's done and they're placed in a nursing home and then they're reassessed, I'm assuming, how frequently are they reassessed?
I should know this. MDS, recurrent?
Quarterly?
Quarterly.
Okay, so quarterly, and so their tier level changes or their needs change. They're in the nursing home. My assisted living's across the street from Jim Cooper, so are Jim and I going to be running patients back and forth between each facility when their tier level changes? And,
I'm not sure why
elderly or not.
I'm not sure why that would happen. Help me understand or what you're suggesting we do.
Well, I think that has to be considered because the elderly cannot handle being moved. I mean, that can change their whole mentation. It can take them to another level of their dementia. I mean, when you move someone that's in their 90s, to a different environment, I mean, it just totally changes their entire lives and every aspect of their being. And so I was sitting here earlier thinking, we're all so concerned about the payment process, but have we lost sight of who we're caring for?
So I can answer that one right now. No, and here's the proof. Because we do not account for that patient. We pay the same no matter what now. We need to fix that because of the patient. We need to fix that because of the patient. We right now do not pay sufficiently for the highest needs patient. We overpay for the lowest needs patient because we haven't taken their specific needs into account in the way we pay, and we need to fix that. That's our fault as a payer. If you look anywhere in medical care or in the rest of the Medicaid program, unfortunately, you'll find a lot of the same thing, where we have paid, we haven't taken account of the patient, and we need to fix. That's why we're here.
In assisted living, in the Living Choices Waiver Program, we're paid on a tier basis, and the DHS nurse comes annually and evaluates them, or we can request them to come at other times, and so we are paid on a tier level based on what their needs are. I just want us to remember who we're caring for, and that we are not, the DHS nurse comes out and says, oh, I'm sorry, you don't meet nursing home requirement anymore, so you're going to have to go to assisted living, or you're going to have to go back home. And as Peggy said, they may not have a home anymore. Their family lives in Colorado, they live in Arkansas. What's going to happen to that resident, or what's going to happen to that patient?
Very, very helpful feedback, and the kinds of dimensions of need or circumstance that we're going to want to try to incorporate.
That we don't leave with any things. I think that's a really important point, and I'm not sure I've heard anything from Andy today that would suggest that would be the case. So the reassessment, can you just go back to the page, the wheel?
Yeah.
Yeah, I'm not sure which page number that was. There was so the reassessment that takes place through the MDG, yeah, that page, I think is designed to help drive the episode payment for the following year. I think you're raising an important thing to look out for, but I think I would be disappointed if folks walked away from the room thinking that we'd suggested that we were moving people around every 3 months. I don't think that's what we said.
Yeah, I think unfortunately the battle lines in community versus institutional placement were drawn so long ago that it's hard for us to think in a new realm. Payment in institutional setting may not actually be the same thing. So we're trying to make sure it matches. In so doing, you're suggesting factors and characteristics that ought to be taken into account. In my simple language, that means here's the formula for need and what it ought to include. And that's what I hear you suggesting, and that's just as you have to provide those inputs when we talk about heart catheters. I cannot tell you the first thing about what a heart cath really entails, the kind of patient, nothing. And it takes 100% input from clinical advisors, internal and external, in the community to tell us what need is. And in this case, there'll be medical components. Obviously, we're looking at the RUG 4, and then you guys telling us.
I don't mean to minimize your comment about the fact that how much family support somebody has makes a big difference, and then how much paid help they have to have. But even in the example that you said, like where a family's working, caring for somebody in the evenings and on weekends, there are things like adult daycare where we have people all the time drop somebody off at 7:30 in the morning, pick them up on their way home at 5:30. So sometimes it's surprising, that the degree to which clients' needs can be met in a community-based setting, even because the folks that are in there would be some of the more needy clients in a nursing home. But I do agree with your statement that the level of support the person has really affects the extent to which they have to count on paid help.
Right up here at the third row.
I'm David Norris with the Arkansas Healthcare Association. I agree with what Elaine and Liz says, but in my experience in working over multiple counties in Arkansas, There's a totally different process in Little Rock and Hot Springs and Northwest Arkansas versus Jasper and Newton County or Calhoun County. And right now there's 40 plus counties that don't have an assisted living. And so in Little Rock, boom, they're out of the nursing facility. When they're out of rehab, they go to the assisted living or they go to home with home care. Newton County, the services aren't developed. And that's where a lot of this I see, I'm like, hey, this will work great in Benton County. But what I see in Texas, I mean, like I have operations, and when we work with people in Texas, what's happened in Texas is they haven't adequately funded dementia care in skilled nursing facilities. And so the nice skilled nursing facilities in Texas can't afford to care for people with dementia, and so they live in slum type areas and things. And so we've got to figure out some way to it's almost like different systems between urban and because we don't have, and we may be on a 5 adult daycare would work great, just like Elaine said. How many adult daycares are in the state? There's not enough. And so whether there might be a 5-year process of we've got to build infrastructure with assisted livings more and figure out how to get them into rural counties and how to develop this infrastructure somewhat before these different, let's say hypothetically, if we did have 2,500 people in nursing facilities that could go out, there might be places for them to go in Little Rock and Hot Springs, but there's not in some of the rural counties.
So we need, I hear a couple of suggestions there. One is account for dementia in the payment, and also, and we're heading here. And this is what I would like. We need to know. Remember, I made the comparison to the patient-centered medical home, where the things that we're asking of the primary care, they can't actually do right now because it may take a clinic the size of one here in Little Rock to achieve, through scale, efficiency, what we're asking, but that doesn't match Jasper. Right now, today, we are out with a request for qualification for statewide vendors to provide that service in Jasper to that local doc. So that's an example of creating, sometimes you have to create the infrastructure to support the payment model. So that's exactly what we need to know. We need more, what I'm hearing you say, we need more assisted living somehow. We need it fast. Adult daycare. We need the continuum. If we're gonna pay on a continuum, we actually need the continuum. Is kind of what
and I speak from personal. My mother's in a retirement center in I'm in Lonoke County. I'm 25 miles from Little Rock. There's not an adult daycare center. I've used Meals on Wheels for her, and she was able to stay home for another 6 months before she went into the facility, and I appreciate that greatly, as does she, if she could remember now. But there's not that support, and that's the whole part of the whole thing. And then you go back to Liz's comment, because again, there's a concern from her going back and forth for the adult daycare. And I was trying to figure the other day of hiring, someone to stay with her. Well, I leave at 7 in the morning and I don't get back till 6 in the evening. That's 13 hours. I'm going to have someone to take care of her while I'm not there. Although she is probably right now in a lower end of the assessment population that we're talking about.
Right.
So some of it's personal experience, and I utilize these services and we want to, but some of them aren't there, and I think that's a whole part of our other concern is in this whole deal is that, and I know in our facilities we've had several that we've tried to get into home and community based, and it's taken anywhere from 3 to 6 months, and then we've had a couple that have 3 days later, literally 3 days later, they've called and said, will you take them back?
So let me,
they're in the emergency room. We need someplace for them to go.
This is exactly where we're heading. And let me use again the example of patient-centered medical home to illustrate the chicken and egg issue. I don't believe we can wait to change the payment system until we have the full continuum, because who's going to pay for the full continuum in the why would they build it? So, in the patient-centered medical home, we're out for bid for those vendors today. Those bids come in the 18th. And we'll be deciding those vendors, that infrastructure that would be available. Actually, we're not paying them. It's up to the primary care to do it. We'll be making them available and picking them in April. In April. Guess what? April, hopefully, is when we finish the payment design process and begin the promulgation. So the vendors are going to actually see all of that proceed through the policy process right as the state, which is when the state as a whole begins to really engage in the patient-centered medical home and what it is, at the very same time that those vendors are going out to build their networks and make connections and begin marketing to the patient-centered medical home. And that's over the next, and then a few months later, just this summer, we start recruiting primary care into that payment model. So we're matching lockstep the development of that capacity as we make the payment change. Now that's a trick. And we need your help with that. Okay? We have always known that that's maybe one of the biggest challenges. It's a whole lot more challenging than a payment methodology, to be honest. Is matching up essentially the development of the long-term service infrastructure that we want as we implement the payment. They have to go together. Just the financing of it means they have to go together. And so what do we need? We need a few things. Tell us what you think the continuum looks like. Assisted living? Adult daycare? What is it? What does that continuum look like? Part 2, practically speaking, what would it take to build that infrastructure? The problem with waiting 5 years is you never get there. Because we can't pay a certain way with no one to pay for 5 years. If it takes investment money of some kind to make it happen, or transition policies, that can't happen for 5 years. My belief is we sort of have to decide how it's going to work, choreograph it over a set amount of time, probably not 5 years, and then figure out what it takes. From the provider's point of view, if there's not a business model for this, it won't happen. I have to fund, it's not my money, it's taxpayer money. Okay? Taxpayers have to fund the transition if taxpayers want to have the end result, right? We're going to have to choreograph that. That's part of this process. Very exciting. I'm glad we got there tonight. Wasn't even on the agenda. But quality metrics, we're asking for. Okay? Review just the ordering of those classified tiers of performance, just the 4 tiers. Does that make sense? What does the continuum of service look like? What do we need more of or less of or whatever? And how would it actually happen? Then we have a payment model, right? It's going to take knowing all of that to fix the payment model and the transition. Can't pay for something that ain't there. Can't ask someone to build something if we ain't paying for it. Chicken, egg, we're going to have to choreograph that. And I'll give you an example of patient-centered medical home. Now, probably the tougher job. Well, I don't know if anything's tougher than that, but of doing that in long-term care.